Hello and welcome. I'm Catherine Banwell, your host for today's program. Today, we're going to explore how to engage with your healthcare team when diagnosed with myeloma, and we'll discuss the patient's role in care decisions. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Let's meet our guest today. Joining me is Dr. Rafael Fonseca. Dr. Fonseca, welcome. And would you please introduce yourself?
Yes, of course. Happy to do that. And thank you very much, Catherine. I am a hematologist-oncologist, but I specialize in the area of multiple myeloma. I work at the Mayo Clinic in Arizona. I currently serve also as interim executive director for the Mayo Clinic Cancer Center that is at large across the Mayo Clinic enterprise. But at heart, I'm a myeloma doctor, and I love to take care of myeloma patients, and I devote my research and the rest of my academic activities to the field of myeloma.
Excellent. Thank you so much for joining us today. Let's start with a question that's on the mind of many of our audience members. We're hearing that the COVID-19 vaccine is safe, but how effective is it for myeloma patients?
Thank you. I think that's a fundamental question, and it's hard to know precisely how to gauge effectiveness when it comes down to vaccination, because historically we know that is done by measuring antibodies, and there's a number of publications that are addressing this. The concern has been twofold. One is that because the disease itself is something that starts from the person's immune cells becoming cancerous, that perhaps that would prevent them from having a very good response. And number two, and perhaps more importantly, will the treatments that are used for the myeloma, et cetera, or lymphoma, can they interfere with our ability to mount an effective immune response? I think the response is mixed right now. I think I tell all my patients the upside is much better than the downside. I think we have a good record now of the safety of this product. So I encourage everyone to get their vaccination. I think it's important to discuss this with your healthcare provider, because sometimes people say, should I stop a little bit so I can get a better response? And while it's theoretically possible, we don't want people to stop treatment if they don't have to do that. And just my very last quick comment, the good news is that the community transmission is clearly going down as more and more people have participated in vaccination. We have more people who now participate in this level of immunity that we have in the community. So hopefully for patients as well as for their families, the risk of contracting this will continue to decrease.
Yeah, we can only hope. Well, let's learn a little bit more about the disease itself. Dr. Fonseca, to level set with our audience, can you help us understand multiple myeloma?
Happy to do so. So multiple myeloma, it's a cancer form of the bone marrow that arises when the cells that under normal circumstances protect us by the formation of antibodies, these are called the plasma cells, they become malignant. Myeloma is the last stage of a process where, a plasma cell can go through a benign tumor or benign phase, if you may, something we call the monoclonal gammopathy, which, by the way, is quite common. About 2% of people over the age of 50 have this abnormality. So think of it like the colon polyp, a precursor condition. There's an intermediate stage that we call smoldering multiple myeloma, which is just more growth, but not quite at the level that it creates problems for the individual. And then lastly, what we just simply call multiple myeloma, and that is when the growth of those cells becomes of such magnitude that a person starts having problems or starts having symptoms related to that. These cells live predominantly inside the bones in the space we call the bone marrow, and they can do a number of things that actually lead to the symptoms and to the clinical presentation. So, as they just grow in the bone marrow, they take some of that real estate. So a person may experience fatigue, and that is because they have anemia. The myeloma cells are also very characteristic because they can erode into the structure of bones. So the destruction of bones is another feature that we see in patients with myeloma, and that can be either seen on X-rays, or sometimes people will present with symptoms related to bone pain or discomfort with movement or weight bearing. Those are signs that we look for. And lastly, the myeloma cells produce proteins. And some of the fragments of those proteins can be damaging to the kidneys. So occasionally people will present with decreased kidney function and sometimes outright failure of the kidney. So those are the common presentations. It's a disease that mostly affects people in their 70s. It's not something that you can detect through routine testing is just indirectly we start seeing abnormalities, and then we do the right testing. And if anyone is hearing this, of course, they need to have the detailed discussion with their own provider.
Of course, yeah. When a person is diagnosed with myeloma, they usually have a whole healthcare team. Who's typically on that team?
Absolutely. Let me start by saying the key to the successful management of myeloma is to have a well-organized team. It's a disease that requires an integrated approach that usually brings around the patient a physician. As part of my team, we also have advanced practice providers. So we work with nurse practitioners that help us do the longitudinal care of patients. We have the nursing team. So every time I meet a new patient, I make it a point to bring my nursing team into the room so they can put a name and a face together, as patients will be interacting, of course, with the nursing team through the portal and the various visits. We have the team that is in charge of the chemotherapy administration. So that's usually a separate nursing team that is in charge of the administration of the medications. But we really don't stop there. We have pharmacists who help us review the medications for our patients. And very importantly, we have social workers that help us address psychosocial needs, as well as some of the practicalities that become inevitable when one deals with a serious diagnosis like multiple myeloma.
Yeah. Lately, we've been hearing this term shared decision making, which basically means that patients and clinicians collaborate to make healthcare decisions. And it can help patients to take a more active role in their care. I'd like to get your thoughts, Dr. Fonseca, on how best to make this process work.
We are very fortunate to live in this time of medicine where ultimately we recognize that the patient is the person expert, and it is the patient decisions that should drive what is to be done in a situation. So whenever I interact with patients, I tell them, listen, I'm going to be like your counselor. I will provide you with options of what I think is reasonable. And I will go to different degrees of effort in trying to convince you one way or another for a particular intervention. But at the end of the day, I only do a good job if I present you with the options and the pros and cons of those various approaches. And I weave that into my language on every single conversation we have with patients. I think we're way past the time where, a physician would come and say, this is what you're going to do, or this is what will happen. My language always includes, I would recommend this. I think the next best step for you to consider would be X, Y, or Z. But ultimately, I look at patients and not infrequently at the person next to them, a family member or a close friend. And I say, you're the boss, and, with the person next to you, providing additional support, comment, and guidance, we can together reach the best decision of what should proceed. And I think we're incredibly fortunate because patients have access to sophisticated information, especially patients that have serious conditions such as would be cancer, and in my case, myeloma. And as an example, when I work with residents, general internal medicine residents that work with me, learning about hematology, I sometimes tell them, you want to walk into a room. Are you going to be seeing what I say? This is like a tennis match between professionals. And you're going to see the level of questions that patients are going to be asking me. And they're going to be asking me about the latest study that was presented at this meeting and the p-value and, this and that. And I can guarantee you that you would not have the tools to be able to address all those questions simply because there's such a, in-depth understanding of the disease. Now, I realize this is not everyone. I'm giving you an extreme example. There's individuals that need additional support, more resources. But just to interact with someone who has such commitment to understand their disease and to help us by that understanding make the right decision makes my job so much more rewarding.
Well, what do you think is the role of a patient then in their care?
I think it needs to be describing in some detail, and there's a lot to unpack there. Of course, patients are dealing with a very serious diagnosis, and it's okay to have periods where they are, in a pause moment and they're reflecting of what they're facing and that they can gather information from close family members. I think we as providers in the medical team needs to deliver a message that provides clear options for them as far as what the best next phase of their treatment or their management might be, including observations or supportive care. But the patient ultimately is a person who has to make that decision. I frequently get the question, and this is not surprising, and it happens all the time. And patient tells me, "Well, what would you do if this was a family member?" And I always tell them, I always talk to you as if you were my family member, as if you were my brother, my mother, my father, so that I try to live deeply to that fiduciary responsibility I have to your well-being. I recognize that there are circumstances, and that's part of the finesse and the art of medicine, that I have to help a little bit more, walk you through that step. And sometimes it's just human that one may want to say, I just want to disconnect. Maybe I'm not the person that wants to go and read in detail, but perhaps I have my daughter or my son who are helping me and understand better where things are. I think one of the key aspects of my role is to make sure that I have a sense that the person has a good understanding to be able to make an informed decision. And at the end of it all, if the person decides to proceed in such a way that doesn't necessarily align with what I'm trying to do, I'm deeply respectful of that choice. Now, I will go to extra lengths. So if someone is foregoing treatment, when I know their treatment has a high likelihood of improving their quality of life, relieve a symptom, or improve survival, I don't think I would do a good job if I don't present why that's so important. But ultimately, it is the patient's decision.
Mm-hmm. Well, related to what you've just been speaking about, we have a question from the audience. This one is from Sarah. Her question is, what advice do you have for caregivers? How can I be supportive during appointments?
That's a great question. And I have experienced this both as a physician as well as a caregiver myself to someone who has had cancer. I think I'm going to say that there are several roles that caregivers play. Some of them are obvious, and I'm gonna call them practical or perhaps even pedestrian. Organizing kind of the activities of every day, and that's important. But a lot of people can do that. The second role is to be in assistance for the knowledge that is needed for some of this decision making. And sometimes patients can be overwhelmed, and we need some support and some vetting and peer process from a trusted and a loved person, so you can go through that, and that is very helpful. But what is essential, and the number one thing, is you are first and foremost the loving family member or friend of that individual who's living through a very profound human experience. And I think the first role of a caregiver has to be to express that role. And I myself reflect on moments where perhaps in a quick reactive way, I wanted to solve some of the immediate practicalities. Mm-hmm. And what was needed most was a direct support. So even, if I face a situation today, if I was, again, a caregiver for someone with a serious diagnosis with cancer, I would start with that priority. Number one, you're the support and the loving person. Number two is I'll try to provide information. And number three, hopefully you can help with meals and the driving and what have you. But there's many more people who can come and help in that regard. Not a lot can do the first part.
Right. Absolutely. Yeah, those are excellent points. Let's talk about treatment goals. What are the goals of myeloma treatment from a clinical perspective?
I've been very fortunate also to live through this era when we have seen a plethora of studies and new drugs being approved for the treatment of myeloma. So when I first started, I kind of used to say, no one wanted to do myeloma because we didn't have good treatments. People wanted to study leukemia, lymphoma. And it just turns out that this is probably one of the most vibrant areas of hematology from a science and from a clinical research perspective, of course. Mm-hmm. If I see young patients who have multiple myeloma, I have essentially two goals. The first one is to induce the deepest possible response I can do so in a safe manner. So, I always repeat in a safe manner, but I really have the goal to try to induce the deepest response possible because that has translated and continues to translate and in many ways proven to be associated with an improvement on the longevity and the time we can control the disease. And it leads me to the second goal, and that is that I firmly believe there is a subset of myeloma patients that are cured from their disease. Now, this is possible because of the availability of these new treatments. I will only be able to say that 10 and 15 years from now, when we have monitored patients for a long period of time, and we have been able to see that became true. But by all indicators, we have patients that are living many, many years without the disease coming back. So I think that would be important.
Yeah.
Now, We have patients that are with more advanced age. Sometimes it's difficult to propose some of the most intense form of treatments like stem cell transplants. We don't do a lot of that in individuals over the age of 75, just because the toll that it takes on a person is very high and the risks become higher. But still in that population, providing the best treatment possible becomes a goal, because I think more and more we're seeing patients in that age category that can start to get close to what normal life expectancy would be. It's not there, it's not perfect, but you start to get close. And lastly, if someone asks me, I have that balance between quality and quantity. The good news in myeloma, if you do it right, quantity and quality go hand in hand. So effective treatment provides symptom relief and provides durability of responses.
That's excellent. What other factors do you consider when determining a treatment approach?
The human experience that comes to the bedside as we consider, treatments, it's so multifactorial and multi-complex that all of that needs to be brought into consideration. So whenever I walk into the room, I tell residents, usually kind of the medical part can be resolved pretty quick. But we're reading, how much can we communicate? What's the level of understanding? What do I understand about the support system for this person? Is this someone who can drive to the treatment center? Is this someone perhaps whose other medical conditions would create certain challenges in how they're going to be treated? This person is telling me they do daily, hikes for 4 miles. Well, that's different from someone who I see comes into the clinic and has to use a cane. So we try to integrate all of that information to make the right decisions. I've made a lot of my career in the early years, working and showing how, for instance, genetic factors are important. And I've come to realize later in my career and through, some of the very elegant work that other colleagues have done, that these factors are just as important in determining the ultimate outcome of patients. So, whenever I talk about that clinical experience, there's two things I always tell the residents, and I use the residents a lot because I think it's a good example of how we aspire to interact with patients. Number one is every single encounter is a final exam. You have to put your best foot forward. Every single exam is, every single encounter should be considered a final exam. Number two is when I walk into that room, there are three things I do, and particularly the first time I meet a person. So number one is connect, right? We cannot have a conversation, and I'm not going to be able to move forward unless we have a human connection, and I have gained the trust of the patient and the family members that are there. So that's number one. The second point is decide, and that is usually, okay, we're going to do this treatment or that. And that is a small part. Most of the time for me, that's a very small fraction of the time and of the mental energy that I consume. There's cases that are more complicated, but most of the time it's pretty straightforward. So it's connect, decide, do very small, and then on the other end is explain. So that's how, I can connect. I propose we do this, and then why are we going to do it, and what can you expect? And if you can do those three things, I think that goes a long way in establishing a fruitful and a productive relationship with the patient and their families.
Mm-hmm. I would suspect that you also take into consideration the patient's health, their age, maybe test results, side effects, things like that.
Of course. So we look at the medical record, and with the advent of course, the electronic record and all the testing we do, our consideration is quite complex because we have to look at all those factors and, the age and comorbidities. And it's rare that we would take one factor alone that would trump everything else. We usually have to integrate the information. And the same is true when we manage myeloma patients and we're monitoring, their protein levels and their response to treatment. I tell patients, they ask me, okay, what would you do? What's the magic number for this or that? I say, it's a little bit like you're flying a Cessna, plane, and you have all these dials in your dashboard, and that's how we manage the situation. Is the integration of all of that information.
Right. Can you help us understand, Dr. Fonseca, how test results may affect treatment options?
Sure, happy to do that. So, in myeloma, we're very fortunate in that we have, and it's not the topic for today, but we have the best biomarker that exists for any cancer. And that is that we can measure the proteins that are associated with the growth of the cells. And we have multiple tests that we can do, and we do them in the blood and we do them in the urine. And there's simple tests that have been done for decades now that allows to monitor how a person is doing with regards to their disease. And I use the following analogy. Myeloma cells live inside the bones, as I mentioned, in the bone marrow, and they don't come out into the blood, so we cannot measure them. So indirectly, we can measure how many they are and how they are behaving by measuring this protein. So I use the analogy of, imagine you're walking in a street and you see smoke coming out of a building. So there are two things you can do. First is you diagnose that there is a fire inside the building, right? And we see that with myeloma by measuring these abnormal proteins. But then as a fighting team comes on, you can gauge whether they're making progress or not by the amount of smoke that comes out. And that's exactly what we do when we monitor myeloma. We monitor the M spike, the serum free light chain, the urinary proteins, and that's how we make those determinations. Now, at the same time we do that, we have to look indirectly at the rest of the body. So we have to look at the kidney function, we have to look at the blood counts, we have to look at the hemoglobin and the red cell count, because that can A, start on the wrong foot because of the myeloma itself, but B, can also suffer as a consequence of our treatments. So it is, again, that idea of having the multiple dials in a dashboard that allows to reach our practice, and we have to be adjusting. So if we measure the proteins and we're doing great, but then at the same time we see we're suffering in blood counts, then we may need to adjust doses or provide supportive treatment. If we don't see the proteins go down, then that may mean we need to change to a different form of treatment, or that the person is unfortunately, refractory or relapsing to something. So that's how we integrate the test results into our management.
Yeah. What sort of questions should patients consider asking about their treatment plan?
I think it's important that patients understand a few things, and they can be described in multiple ways. Number one is, of course, what is it that is being used, right? So I think that includes a description of what to expect, the practicalities, the names of the medications, their side effect profile, and what to report when you use those medicines. So I think that's very, very important. Because if you're empowered with that information, you're going to be better off as you react for symptoms that may come along. I always tell patients, when you have a cancer diagnosis, your self-awareness goes through the roof, because we're going to be paying attention to everything, every skin change, every pain we have. So I think having a bit of that proactive discussion becomes important as they think about, the treatment. So the what. I think the how to and the practicalities are very, very important. That's where the nursing team and the pharmacists help us a lot too. Do you take the medicines at night? Do you take them with meals? Is there something that you shouldn't be mixing? How much time would it take for me to get a refill? It's different to get a medication from a specialty pharmacy versus your down the street Walgreens. So all of those things is important that patients, again, participate in the understanding. And if not them, at least the caregivers that are part of this team. I think it's important that patients ask also some brief descriptions of the biology of the disease. If I have myeloma, what type of myeloma do I have? Does that matter as far as what treatments I'm going to be using? What treatment options may be available to me because of my specific subtype? And we have subsets of myeloma that have options that are not available to others. And also, I think it's important that patients also ask, a sense from the physicians as to where they are. And I'd like to, describe this a little bit more. Sometimes patients ask us specific questions about, am I in a complete response? Am I in a very good partial response? And what is a PFS? Those terms work very well when we talk about clinical trials, but they don't necessarily describe in a great way the situation for an individual patient. And I use a lot more adjectives than I use technical terms when I describe where patients are. So I say, you have an excellent response. You have a very deep response. And then I provide more details if they want. Yes, you're MRD negative at 10 to the minus 6. But, sometimes I find that it's harder for patients to understand where they are if they completely focus on the, staging system or the response criteria, et cetera. Because, maybe a VGPR or a very good partial response doesn't sound very good, but then you can be in a very good partial response for 15 years and it doesn't matter. You may want to be on an MRD negative status, but you still have a good outcome. And that's why the general description of the status by the physician becomes important.
Mm-hmm. Do you think patients should get a second opinion consult with a specialist?
In general, my answer is going to be yes, and this is not self-serving. I think myeloma has become so complex that trying to integrate at least once, or if not in some infrequent basis, the opinion of a myeloma specialist becomes important. And this is no one's fault. If you're a community oncologist somewhere where myeloma represents only a small fraction of your practice, I can guarantee you cannot stay on top of the literature. I cannot stay up with everything that goes on myeloma, even though that's what I do 100% of the time. I get an email every week with all the articles, all the publications, and I have to integrate that. And I have to think, okay, does this matter or not? I go to the professional meetings, I see all the abstracts, and I still feel like I'm missing out. How could you do that if that is only a small fraction of your practice? And I'm sure that the same applies for other cancers, breast and colon. Now, you can't move, you cannot, uproot yourself and leave your community and your family. But I think there should be ways by which patients at least have an opinion from someone who has more expertise. Unfortunately, there are many centers across the nation now that have that expertise for the management of myeloma.
Yeah. Dr. Fonseca, we have a question from a newly diagnosed myeloma patient. Barbara says, I'm just about to begin my first myeloma treatment. What can I expect?
Yes, thank you, Barbara, for the question. I think if you start on treatment, first of all, I hope they already went through a good description of what the treatments are, the frequency by which you're going to have to go to the center, and also what are the toxicities to look out for. Mm-hmm. One of the most common toxicities that we face, and one of the most challenging parts of initial treatment, is the use of steroids. So we use dexamethasone as part of every single regimen we use for myeloma. And I tell patients, dexamethasone is a simple drug, and at first glance, but it's oftentimes the most complicated part of treatment. The human brain works at triple speed when you're on dexamethasone. So, it's hard to sometimes be able to sleep properly. People can become anxious. And even the sweetest person in the world can become, a little bit edgy when they're on dexamethasone. I would say Mother Teresa on dexamethasone would be an edgy person. So just be patient, work with a team, and just know that on the other side of treatment, there is a return to normal life. And our goal as we embark on treatments, and, for instance, as I see patients that are going to go through transplant, I tell them, our goal is you finish, you recover, and you go back to your life, you go back to work, you go back to your family, your kids, your sports. And that's really what we strive for when we treat patients with myeloma.
Yeah. Once on therapy, how is the disease monitored, and how do you know if the treatment is working?
Well, fortunately, we use the same markers so that, once a person is on therapy, we will be monitoring, and we monitor at least on a monthly basis those myeloma protein markers. Once a person reaches a great level of response, sometimes we complement that with an analysis of the bone marrow. Of course, it's more invasive, so we don't like to do a lot of them, but we do them as needed. As we go forward and monitor patients, we will be looking for signs that those proteins remain in a low level and stable as an indicator that the disease is under control. Now, if I see someone and then I start seeing that there's an increased concentration of those proteins, or we see something else clinical, we might need to do a little bit of a regrouping and test again in great detail to determine if the person is experiencing regrowth of the disease, the so-called relapse.
Why is it so important for patients to speak up when it comes to symptoms or treatment side effects?
Well, that's a great question. If you don't speak about them, we don't know about them, and it seems very obvious, but then we cannot make the proper adjustments. And I'll give you a couple of examples. I already talked about dexamethasone, but a common drug we use is something called bortezomib. Bortezomib is a proteasome inhibitor. That's a mouthful, but it's one of the key type of drugs we use, and it's given as an injection under the skin. Not to be confused, by the way, with daratumumab, or there's the Faspro is the name of that medication. So not to be confused with that, there's bortezomib, which we have been using for many years. But bortezomib has a potential toxicity that is called the peripheral neuropathy. And if patients have peripheral neuropathy, that can go from very mild, where you have some numbness and tingling, to the more extreme cases that is associated with, pain, discomfort, even weakness and disability. Mm-hmm. Well, if we don't know that that's happening, then we can't react to it, and we can't adjust doses or switch to something different altogether. And you can imagine, now we have more options, but in the old days, I always tell patients, you might be tempted not to say anything about this, because you might be thinking, boy, this is working. I don't want to interfere with my treatment. I can live with a peripheral neuropathy. But if it gets worse, then despite the fact that the treatment is working, the person might have a very significant impingement on their quality of life. And more so now that we have so many alternatives, it's important not to get us into a path that we might reach a point of an irreversible chronic complication from treatment.
Oh, and that would be awful.
Absolutely.
Before we end the program, Dr. Fonseca, have there been any recent developments in myeloma treatment and research that make you hopeful?
Absolutely. And I would say that the one area of work that makes me most hopeful is what we're seeing with immunotherapy. And we have seen that both at the ASH meeting as well as the ASCO meeting. And this year, where people are presenting updates with the various clinical trials with either bispecific antibodies or CAR T-cell therapy as a new avenue for the treatment of myeloma. In fact, at the last ASH meeting, we had 14 presentations of different compounds or different constructs that are active. So, I think that the future is bright in that regard. We're seeing their application right now. And, a lot of these updates also have been made at ASCO. We're seeing the update of, the treatment of patients with fairly advanced and aggressive disease, where we can still show very significant responses. I participate in some of these trials. I can tell you, in my institution, using some of the bispecifics, I see patients who have previously exhausted all other options and now are MRD negative at 10 to the minus 6. And if we're seeing that in the very advanced disease, I cannot wait to see what happens when we start using these treatments in either early relapse and why not in the near future as frontline part of our therapy. So I think to me, that whole field of T-cell engagers, whether it's bispecifics or the CAR T-cells, remains one of the most exciting areas for future research.
So how can patients stay up to date with on information like this?
I think what we alluded to before is very important to work with groups like yours and other patient support organizations that can keep them up to date. I think they're doing a very good job and also providing updates post, some of the large meetings. I know there's a lot of patients out there that are very sophisticated that will even join the medical meetings, and that happens with some frequency, that they want to learn. And patients that go and ask me details about the statistics of the trial. So that's a whole spectrum, right? But at the minimum, I would say a strong connection with a support group or a patient, support organization becomes an imperative as you deal with this. And also that would help you because, there's with this whole concept of, the information not always being completely truthful, that can be scary as well too. If someone goes and just looks for, I would say even sort of the resources that are out there in a textbook today, well, just keep in mind that textbook was probably written 5 years ago and it represents the studies of about 10 and 15 years ago. How that relates to you, it's very distant. So it is because of this continuous process of research that we know better what's going on at the present time.
Dr. Fonseca, thank you so much for taking the time to join us today.
Oh, it's my pleasure. And thank you for the opportunity.
And thank you to all of our partners. To learn more about myeloma and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for joining us.